Hello, everyone. So we will be continuing with chapter 10 of illustrated textbook of pediatrics, that is perinatal medicine. Meconium aspiration. The passage of meconium becomes increasingly common the greater the infant's gestational age, particularly when post-term. Infants who become acidotic may inhale thick meconium, develop meconium aspiration syndrome. Attempting to aspirate meconium from the nose and mouth while the infant's head is on the perineum is not recommended, as it is ineffective if the infant cries at birth and establishes regular respiration. No resuscitation is required. If respiration is not established, initiating lung inflation within the first minute of life is the priority. If the baby was born through thick meconium, it is reasonable to inspect the oropharynx rapidly and remove any thick meconium by suctioning with a large bore suction catheter. But if the infant becomes bradycardic, positive pressure ventilation to aerate the lungs is indicated despite the presence of meconium. Resuscitation of the preterm infant. Preterm infants are particularly liable to hypothermia, and every effort must be made to keep them warm during resuscitation. Infant of less than 30 weeks gestation should, with the exception of the face, be placed into a plastic bag or wrapped in clear plastic sheeting without drying to allow the plastic to cling to the skin. A radiant heat source from the resuscitation table or thermometrist can then warm the baby in a bag wrap, which acts almost like another layer of skin by avoiding evaporative heat loss. Excessive tissue oxygenation may cause tissue damage to the brain, lungs, and eyes from oxygen-free radicals, whereas air is used for initial resuscitation in term infants. A low concentration 21 to 30% should be used for preterm infants, and air oxygen mixture should be used, and any additional oxygen given should be titrated against oxygen saturation, thus avoiding exceeding a preductal saturation of 95%. Preterm infants less than 30 weeks gestation may benefit from non-invasive respiratory support in the form of CPAP, continuous positive airway pressure, to avoid the need for intubation. Very premature infants may develop respiratory distress syndrome, and early tracheal administration of artificial surfactant may be indicated. Resuscitation of infants at the threshold of viability at 22 to 24 weeks gestation raises particularly difficult ethical and management issues. An experienced pediatrician should be responsible for counseling the parents before delivery, if possible, and lead the management of the baby after birth. Post-resuscitation care. If following resuscitation, the baby is significantly preterm or ill, the infant will need to be stabilized before transfer to the neonatal unit. Particular attention needs to be paid to provide adequate respiratory support and to the prevention of hypothermia and hypoglycemia. Failure to respond to resuscitation. Decision to stop resuscitation is always difficult and should be made by a senior pediatrician. The longer it takes the baby to respond to resuscitation, the less likely is survival. If there is no breathing or cardiac output after 10 minutes of effective resuscitation, further efforts are likely to be unproductive, and consideration should be given to stop resuscitation. If prolonged resuscitation has been required, the infant should be transferred to the neonatal unit for assessment and monitoring. Size at birth. And infant's gestation age and birth weight influence the nature of the medical problems likely to be encountered in the neonatal period. In the UK, 7% of babies are of low birth weight, less than 2.5 kgs. However, they account for approximately 70% of neonatal deaths. Now, definitions. Babies with a birth weight below the 10th centile for the gestational age are called small for gestational age. or small for dates. The majority of these infants are normal but small. The incidence of congenital anomalies and neonatal problems is higher in those whose birth weight falls below the second centile, approximately 2 standard deviations below the mean, and some authorities restrict the term to this group of babies. An infant's birth weight may also be low because of preterm birth or because the infant is both preterm and small for gestation age. Just small for gestation age infants may have grown normally but are small, or they may have experienced IUGR, that is, they have failed to reach their full genetically determined growth potential and appear thin and malnourished. Babies with a birth weight above the 10th centile may also be malnourished. For example, a fetus growing along the 80th centile that develops growth failure and whose weight falls to the 20th centile. Patterns of restriction. Growth restriction in both the fetus and infant has traditionally been classified as symmetrical or asymmetrical. In the more common asymmetrical growth restriction, the weight or abdominal circumference lies on the lower centile than that of the head. This occurs when the placenta fails to provide adequate nutrition late in pregnancy, but brain growth is relatively spared at the expense of liver glycogen and skin fat. This form of growth restriction is associated with uteroplacental dysfunction secondary to maternal preeclampsia, multiple pregnancies, maternal smoking, or it may be idiopathic. These infants rapidly put on weight after birth. However, this is associated with an increased risk of obesity and type 2 diabetes in later life. In symmetrical growth restriction, the head circumference is equally reduced. It suggests a prolonged period of poor intrauterine growth starting in early pregnancy, or that the gestational age is incorrect. It is usually due to a small but normal fetus, but may be due to a fetal chromosomal disorder or syndrome, a congenital infection, maternal drug and alcohol abuse, a maternal chronic medical condition, or malnutrition. These infants are more likely to remain small permanently. In practice, distinction between asymmetrical and symmetrical growth restriction often cannot be made. This figure showing the birth weight of small for gestation age infants is below the 10th centile for the gestation. Small for gestation age infants may be preterm, term, or post-term. A picture showing severe intrauterine growth restriction in a twin. Monitoring the growth restricted fetus, the fetus with IUGR is at risk from intrauterine hypoxia and unexplained intrauterine death, asphyxia during labor and delivery. The growth restricted fetus will need to be monitored closely to determine the optimal time for delivery. Progressive uteroplacental failure results in reduced growth in female length and abdominal circumference, oligohydramnios from reduced fetal urine production, abnormal umbilical artery Doppler waveform, absent or reversed end diastolic flow velocity due to increased placental impedance, redistribution of blood flow in the fetus, increased flow to the brain, reduced flow to the gastrointestinal tract, liver, skin, and kidneys, abnormal ductus venosus Doppler waveform from cardiac dysfunction, reduced fetal breathing and movements, abnormal fetal heart rate trace. The growth restricted infant after birth, these infants are liable to hypothermia because of the relative large surface area, especially the head, hypoglycemia from poor fat and glycogen stores, hypocalcemia, polycythemia, venous hematocrit, more than 0.65. Now the summary: size at birth, small for gestation age, birth weight less than 10 centile, IUGR fails to reach genetically determined growth potential, growth restriction, symmetrical and asymmetrical, but often mixed. Large for gestation age infants, large for gestational age infants are those above the 90th centile for their gestation. Most are normal, large infants, but it's a feature of infants or mothers with either type 1 or gestational diabetes or a baby with certain congenital syndromes, for example, Beckwith-Wiedemann syndrome. Problems associated with being large for gestation age are birth trauma, especially from shoulder dystocia at delivery, difficulty delivering the shoulder from impaction behind maternal symphysis pubis, birth asphyxia from a difficult delivery, hypoglycemia due to hyperinsulinism, polycythemia, breathing difficulty from an enlarged tongue in Beckwith-Wiedemann syndrome. Now, the routine examination of newborn infant. Immediately after a baby is born, parents are naturally anxious to know if their baby is all right and appears normal. To answer this, the midwife or the pediatrician or obstetrician, if present, will briefly but carefully check that the baby is pink, breathing normally, and has no major abnormalities. If a significant problem is identified, an experienced pediatrician must explain the situation to the parents. If the baby is markedly preterm, small, or ill, admission to a neonatal unit will be required. Should there be any uncertainty about the child's sex, it is important not to guess but to explain to the parents that further tests are necessary. Babies are given vitamin K at birth to prevent hemorrhagic disease of the newborn unless parents will not give consent. Within 72 hours of birth, every baby should have a full and thorough examination. The routine examination of the newborn infant, its purpose is to detect congenital abnormalities not already identified at birth, for example, eye abnormalities, congenital heart diseases, undescended testes, or developmental dysplasia of the hip. Check for potential problems arising from maternal disease or familial disorders. Provide an opportunity for the parents to discuss any questions about their baby. Before approaching the mother and baby, the obstetrician and neonatal notes must be checked to identify relevant information. The examination should be performed with the mother or ideally both parents present. Many findings in the newborn resolve spontaneously. Common significant abnormality detectable at birth are listed. A serious congenital abnormality is present at birth in about 10 per thousand to 15 per thousand live births. In addition, many congenital anomalies, especially of the heart, present clinically at a later stage. In the UK, the newborn examination is repeated at 6 to 8 weeks of age, usually by the general practitioner. Red reflex to identify eye abnormality. See case history for a case study of red reflex. Detection of undescended testes in boys is usually detected on newborn examination. It is described in the next chapter. Checking for developmental dysplasia of the hip. To check the DDH, previously called congenital dislocation of the hip, the infant needs to be relaxed, as kicking and crying resulting in tightening on the muscles around the hip and prevents satisfactory examination. The pelvis is stabilized with one hand. With the other hand, the examiner middle finger is placed over the greater trochanter and the thumb around the distal medial femur. In the Barlow maneuver, the hip is held flexed and the femoral head is gently adducted and pushed downward. If the hip is dislocatable, the femoral head will be pushed posteriorly out of the acetabulum. The next part of the examination is the Ortolani maneuver to see if the hip can be returned from its dislocated position back into the acetabulum while gently abducting the hip. Upward leverage is applied. A dislocated hip will return with a clunk into the acetabulum. Ligamentous clicks without any movement of the head or the femur are of no significance. It should also be possible to adduct the hips fully, but this may be restricted if the hip is dislocated. Clinical examination does not identify some infants who have hip dysplasia from lack of development of acetabulous shelf. DDH is more common in girls, six-fold increase if there is positive family history, 20% of affected infants if the birth is a breech presentation, 30% affected infants, or if the infant has a neuromuscular disorder. Early recognition of DDH is important as early splinting in adduction reduces long-term morbidity. A specialist orthopedic opinion should be sought in the management of this condition. Ultrasound examination of the hip joint is performed increasingly in many hospitals, either following an abnormal hip examination, the presence of neuromuscular disorder in the lower legs, or talipes equinovarus, or to screen babies at increased risk, resuscitation, or positive family history. Ultrasound examination can be performed to screen all babies, but it is not currently recommended in the UK as it is expensive, requires considerable expertise, and there are many false positives. It will, however, identify some babies missed on clinical examination. Routine examination of a newborn infant. Birth weight, gestation age, birth weight, central are noted. General observation of the baby's appearance, posture, and movements provide valuable information about many abnormalities. Baby must be fully undressed during the examination. Head circumference measured with a paper tape measure and centile noted. This is the surrogate measure of brain size. Fontanelle sutures are palpated. Fontanelle size is very variable. Sagittal sutures often separated and the coronal sutures may be overriding. A tense fontanelle when the baby is not crying may be due to raised intracranial pressure, and a cranial ultrasound should be performed due to check the hydrocephalus. A tense fontanelle is also a late sign of meningitis. The face is observed if abnormal. This may represent syndrome, particularly if other abnormalities are present. Down syndrome is the most common, but there are hundreds of syndromes. When the diagnosis is uncertain, a book or a computer database must be consulted, and advice should be sought from a senior pediatrician or geneticist. If plethoric or pale, the hematocrit should be checked to identify polycythemia or anemia. Central cyanosis, which always needs urgent assessment, is best seen on the tongue. Jaundice within 24 hours of birth requires further evaluation. The eyes are checked for red reflex with ophthalmoscope if absent, may be from cataract, retinoblastoma, and corneal opacity. The reflex can be hard to elicit to darker skinned infants, but the retinal vessels can be visualized. The palate need to be visualized, inspected, including posteriorly to exclude a posterior cleft palate, and palpated to detect an indentation of the posterior palate from a submucous cleft. Breathing and chest wall movement are observed for sign of respiratory distress. On auscultating the heart, the normal rate is 110 to 160 beats per minute in term babies, but may drop to 85 beats per minute during sleep. On palpating the abdomen, the liver normally extends 1 centimeter to 2 centimeter below the costal margin. The spleen tip may be palpable, as may the kidney on the left side. Any intra-abdominal masses, which are usually renal inversion, need further investigation. The femoral pulses are palpated. The pulse pressure is reduced in coarctation of aorta. This can be confirmed by measuring the blood pressure in the arms and legs. Increased if there is patent ductus arteriosus. Genitalia and anus are inspected on removing the nappy. Patency of the anus is confirmed in boys. The presence of testes in the scrotum is checked by palpation. Muscle tone is assessed by observing limb movements. Most babies will support their head briefly when the trunk is held vertically. The whole of the back and spine observed, looking for any midline defects of the skin. Primitive reflexes are checked, including the grasp and motor reflexes. For asymmetric or reduced movements, the hips are checked for DDH. This is left until last as the procedure is uncomfortable. Vitamin K therapy. Vitamin K deficiency may result in hemorrhage disease of the newborn, a rare condition with an incidence of 0.6 per 1 lakh births. The disorder can occur early during the first week of life or late from 1 to 8 weeks of age. In most affected infants, the hemorrhage is mild, such as bruising, hemitemesis and melena, or prolonged bleeding of the umbilical stump or after circumcision. However, some suffer from intracranial hemorrhage, half of whom are permanently disabled or die. Breast milk, which has many benefits to both the mother and baby, is a poor source of vitamin K. whereas infant formula milk has a much higher vitamin K content. Hemorrhagic disease of newborn may occur in infants who are wholly breastfed but not if fed with an infant formula. Infants or mothers taking anticonvulsants which impair the synthesis of vitamin K dependent clotting factors are at increased risk of hemorrhagic disease both during delivery and soon after birth. Infants with liver disease are also at increased risk. Disease can be prevented if vitamin K is given by intramuscular injection, and in the UK, it was widely given to all newborn infants immediately after birth. In the early 1990s, one study suggested a possible association between vitamin K given intramuscularly and development of cancer in childhood, but this has not been found in other much larger studies. It is recommended that all newborn infants are given intramuscular vitamin K. However, parents may request oral vitamin K as an alternative, as absorption via the oral route is variable. 3 doses are needed over the first 4 weeks of life to achieve adequate liver storage. Mothers on anticonvulsant therapy should receive oral prophylaxis from 36 weeks gestation, and the baby should be given intramuscular vitamin K. Vitamin K should be given to all newborn infants to prevent hemorrhagic disease of the newborn. Now, the lesions in a newborn infant that resolve spontaneously. Peripheral cyanosis of hands and feet common in the first day. Traumatic cyanosis from a cord around the baby's neck or from a face or brow presentation cause blue discoloration of the skin, petechia over the head and neck or affected part, but not the tongue. Swollen eyes and distortion of shape of the head from the delivery. Subconjunctival hemorrhage occur during delivery but should be documented to avoid confusion with non-accidental injury when older. Small white pearls along the midline of the palate, Epstein pearls, cyst of the gums, epileus or flora mouth, ranula. Breast enlargement may occur in newborn babies of either sex. A small amount of milk may be discharged. White vaginal discharge, a small withdrawal bleed in girls. There may be a prolapse of the ring of vaginal mucosa. Capillary hemangioma, stomach bites. Pink macules on the upper eyelids, mid forehead, and nape of the neck are common and arise from distension of the dermal capillaries. Those on the eyelids gradually fade over the first year. Those on the neck become covered with hair. Neonatal urticaria erythema toxicum, a common rash appearing 2 to 3 days of age, consisting of white pinpoint papules at the center of the erythematous base. The fluid contains eosinophils. The lesions are concentrated on the trunk. They come and go at different ages. Milia, white pimples on nose and cheek from retention of keratin sebaceous material in the pilosebaceous follicles. Mongolian blue spots, blue-black macular discoloration at the base of the spine and on the buttocks, occasionally occur on the legs and other parts of the body, usually but not invariably in Afro-Caribbean or Asian infants. They fade slowly over the first few years. They are of significance unless misdiagnosed as bruises. Umbilical hernia, common, particularly in African-American, no treatment is indicated that it is usually resolves within the first 2-3 years. Positional talipes, the feet often remain in their utero position. Unlike true talipes equinaris, the foot can be fully dorsiflexed to touch the front of the lower leg. Caput secundarium and cephal hematoma. Breast enlargement we have. Then there is erythema toxicum. Neonatal urticaria often has a raised pale center. Milia and Mongolian blue spots, positional talipes, appearance at birth. Foot can be fully dorsiflex. To touch the front of the lower leg in true talipes equinovarus, this is not possible. Some significant abnormalities detected on routine examination. Port wine stain, nevus flammeus, present from birth and usually grows with the infant. It is due to a vascular malformation of the capillaries in the dermis, relief along the distribution of the trigeminal nerve. It may be associated with intracranial vascular anomalies, Sturge-Weber syndrome, or severe lesions on the limbs with bone hypertrophy, Klippel, Tranone syndrome. Disfiguring lesions can now be improved with laser therapy. Strawberry nevus cavernous hemangioma, usually not present at birth but appear in the first month of life and may be multiple. They are more common in preterm infants, increase in size until 3 to 15 months of age, then gradually regress. Not treatment. No treatment is indicated for small lesion, but topical propranolol may speed regression. Large lesions of or if interfere with vision or the airway are treated with oral propranolol. Ulceration or hemorrhage may occur. Natal teeth consisting of front, lower incisors may be present at birth. If loose, they should be removed to avoid the risk of aspiration. Extra digits are sometimes connected by a thin skin tag but may be completely attached containing bone and should ideally be removed by a plastic surgeon or else tied off at its base. Skin tags anterior to the ear and accessory auricles should be removed by a plastic surgeon. Heart murmur poses a difficult problem as most murmurs audible in the first few days of life resolve shortly afterwards. However, some are caused by congenital heart disease. If there are any feature of significant murmur, upper and lower limb blood pressures and preductal and postductal pulse oximetry should be checked, followed by an echocardiogram. Otherwise, a follow-up examination is arranged and the parents want to seek medical assistance if their baby feeds poorly, develops labored breathing, or becomes cyanosed. Midline abnormality over the spine or skull, such as tuft of hair, swelling or nevus, requires further evaluation or may indicate any underlying abnormality of the vertebra, spinal cord, or brain. Palpable enlarged bladder if there is urinary outflow obstruction, particularly in boys with posterior urethral valves, requires prompt evaluation with ultrasound, usually diagnosed on antenatal ultrasound. Telepiece equinaris cannot be corrected as in positional telepiece. Pictures are shown, and then there is a case history. The case history shows the congenital cataract. On checking the red reflexes during the routine newborn examination, bilateral absent red reflexes were noted in a male term baby. The remainder of the examination was normal. Urgent ophthalmology review confirmed bilateral congenital cataract, presumed idiopathic, but many are genetic. These occur in about 3 to 4 per 10,000 live births and is responsible for about 10% of blindness in children worldwide. Early surgical treatment is the first few weeks. In the first few weeks of life improves long-term visual functions. Other abnormalities that may be detected are congenital glaucoma and coloboma. Eye abnormalities on newborn examination, congenital glaucoma of right eye and iris coloboma, keyhole-shaped pupil due to defect of the iris inferiorly. The next picture shows Barlow maneuver and femoral head dislocation posteriorly out of acetabulum, and Ortolani maneuver is dislocated femoral head relocated back into acetabulum. Now, the prevalence of serious congenital abnormalities per 1,000 live births, England and Wales. Congenital heart disease is 6 to 8.8 on the first day of life, and DDH is 1.5, but about 6 by 1,000 have an abnormal initial clinical examination. Telepiece is 1, and Down syndrome is 1. Cleft lip and palate is 0.8. Urogenital hypospadias and descended testes is 1.2. Spina bifida and encephaly is 0.1. Now, neonatal hearing screening. Universal screening has been introduced in UK to detect severe hearing impairment in newborn infants. Early detection and intervention improves speech and language. Autoacoustic emission OAE testing, in which an earphone is placed over the ear and a sound is emitted which evokes an echo or emission from the ear if cochlear function is normal, is used as the initial screening test. If the normal test result is not achieved, referral is made to a pediatrician audiologist. Testing with auditory brainstem response ABR audiometry using computer analysis of electroencephalogram waveforms evoked in response to a series of clicks may be performed. Newborn hearing screening is performed on all infants to detect severe hearing impairment. Oxygen saturation screening for critical congenital heart disease and increasing performed is increasingly performed in the first 24 hours of life to identify duct-dependent congenital heart diseases as an early diagnosis, and treatment can prevent collapse when the duct closes at 24 to 48 hours after birth. A low post-ductal oxygen saturation or abnormally large difference between preductal right hand and post-ductal movement prompts medical review. An echocardiograph graphs a low oxygen saturation may also occur with respiratory disease or sepsis. Biochemical screening, newborn screening, previously called the Guthrie test, is performed on every baby. A blood sample, usually a heel prick, is taken when feeding has been established on days 5 to 7 of life. In the UK, all infants are screened for congenital hypothyroidism, hemoglobinopathy, sickle cell and thalassemia, cystic fibrosis, 6 inherited metabolic diseases, phenylketonuria, MCAD, medium chain acyl coenzyme A, dehydrogenase deficiency, maple syrup urine disease, isovaleric acidemia, glutaric aciduria type 1, homocystinuria. Details about the inborn error metabolism are described in next chapter. Screening for cystic fibrosis is performed by measuring the serum immunoreaction trypsin, which is raised if there is pancreatic duct obstruction. If raised, DNA analysis is also performed to reduce the false positive rate. In the UK, biochemical screening is performed on all babies to identify congenital hypothyroidism, hemoglobinopathy, cystic fibroma, and 6 inborn error of metabolisms. Thank you very much.